Now we have Adam Burley, and he's a trauma-informed approach to complex needs and service improvement, and he's from the Edinburgh Streetwork Team in the Simon community. Thanks. Adam.
Morning, everyone. Thank you for being here. I know other conferences are available. I should say I'm not going to touch on social and political determinants of trauma and health and well-being. Because I say at another conference, I think there's a woman standing up right now who's going to address those issues right to the core. But it is worth mentioning them at the outset, just particularly on a day, I guess, where Glasgow Centre for Public Health has published a study showing that over 300,000 extra deaths were a consequence of, or appear to be, consequence of austerity from, was it 2012 to 2019. But as I say, I'll let Liz cover that and we'll stick to this. I've been working in this area for a number of years, and a number of things I've learnt, I think. A couple of them are, broadly speaking, that I think we are fundamentally relational as human beings. From birth and through our life, I don't think it stops. And in that regard, I think all human activity and health and well-being is in some way secondary and consequent to the nature and the quality of the relationships that we have in our mind and between ourselves and other people and activities and everything else that we do. I think second thing I would say is I think we have a range of needs, whether they're complicated or multiple, I'm not sure. I think they probably are. But the degree to which we notice them is probably dependent on the degree to which they're being met. I think relationships are a bit like the psychological equivalent of breathing, really, in that we've all been breathing since we entered this room. Most of us have been breathing since we were born, actually, but we don't notice it. We're so good at it, we can rock up to conferences and breathe all day long and don't tend to go home and say, another successful day of breathing. Aren't I clever? But if anyone here is choked, you will get to know very quickly that breathing is addressing a range of multiple and complex needs that when the breathing stops, you become acutely aware of very, very quickly. And I would say the same thing for relationships, really. They're invisible, we can't really see them, so I'm going to try and shine a light on them a bit. But when they choke, and there's lots of reasons why relationships choke, the consequences can be catastrophic, like absolutely catastrophic. But again, we don't tend to notice that. Not many of us will go home today and go, another good day of relating, getting my psychological and emotional needs met through connecting with other people. Aren't I clever? Like, we just won't do that. Well, some of us might. I might after this. Some of you might after this. I don't know. If we're lucky, though, we can get some of our multiple and complex needs, psychological and emotional needs, met through a range of relationships, friends. My partner said I should use a slide that showed them before they had some work done, but it was too late. Or family, like they may be things that we can actually get some of our needs sort of met through in all sorts of ways. Good family, good healthy family. And other things as well. We connect and relate to all sorts of things. I like this slide. It reminds me that there was a time we used to talk about people having addictive personalities, didn't we? Until someone invented the mobile phone. And it turned out we all have addictive personalities. You just need to find the right sort of relationship to sort of get in contact with. So it's not just people we can relate to, it's all sorts of things we can relate to get our needs met. This is, I don't know what's so special about this aisle. This is the aisle in my local Tesco. It's 35 centimetres wider than every other aisle. And it's got this brown floor in it, which I think is meant to be sort of a wood effect, and it has its own strip lighting. And all it sells is liquid. I'm not sure what's so special about this aisle, but it has a special place in the supermarket. It's right in the middle. So I'm assuming it's addressing some need of the population who's using that supermarket. I want to tell you a bit about a particular mental health service, my own really. I get some of my emotional and psychological needs met through relationships with a number of things. This is 3 of them. This is my daughter, my son, and there's Claire in the background going, can we hurry up please, stop fanning around taking pictures of the kids all the time. But these are very much part of my mental health service, as are these. This will set off some neurons in some people's brains in the audience going, yes, they are lovely, aren't they? Yes. That's part of my mental health service. And my records, of course, and hill walking, amongst other things, my colleagues, my friends, all sorts of things that I am in relation to in the external world that keep me sane and relatively sane and relatively healthy. I think, I was going to say, all the time, I think about this a lot. I don't think about it a lot, that would be a bit strange, but occasionally I do reflect on what it would be like if you left me on an island, and disconnected me from all of this. I should probably put the kids back in. The important stuff. And disconnected me from all of this and left me on an island, not for 3 days. Occasionally I go to the hills for 3 days, and it's quite an interesting experience to go by yourself to the hills for 3 days, by yourself, quite disconnected from things. I find about 2 days in, I am genuinely talking to myself. It's quite interesting, it just happens. Start saying, I'll just walk up to that cairn, and then I'll sit down, and then I'll have a sandwich, and it's quite odd. And then I meet people in the car park at the end of it, go, hello, how are you? Where have you been? What are you doing? In a sort of slightly manic way. But what would it be like to be left on an island, not for 3 days, or 3 months, or 3 years, but for 30 years or more, to say, right, you're never going to see any of this stuff again. You're going to be an island, there's enough food and water, you're not going to die, you can stay there, but you're never going to see any of this stuff again. What would I look like after 2 weeks, or 3 months, or 30 years? What would I actually look like? I don't know. Probably not as good as that. But I can imagine you'd rock up after 30 years and I would be in love with a coconut or something, and it would seem perfectly normal. Because most of us, everyone watch this film? Not everyone, but most people. He's in love with a volleyball, isn't he? And we all get it. It's not like we watch this film and go, that's mad. What the hell is he doing being in love with a volleyball? And when it floats away, we all shed a tear, don't we? For the loss of a volleyball. That's how important relationships are to us, that we can watch a volleyball for 2 hours and find ourselves becoming emotionally connected to it in some way. But there are other ways of ending up on an island, I would suggest. And I think one of the ways of thinking about what tends to be described as trauma is that it happens in relationships, typically, if not always, and it gives rise to massive disconnection at its worst. What I might call, what I would refer to as severe relational injury. And by that I mean a real injury in the capacity to form and maintain human relationships in a way that might allow the person to get their emotional and psychological needs met. It's a bit invisible, it's quite hard to see a relational injury. It's like, where is it? It's sort of there between me and the world in some way. But it can be very, very sort of catastrophic, really, and have very, very life-limiting consequences, I think. That's the way I would think about... there's lots of ways I would think about trauma, but for the purposes today, I would think about it in terms of the major impact having, as I say, a severe injury on someone's relational sort of capacities, really. And as a consequence of that, I would argue that it becomes difficult then to get these needs met. The breathing starts to choke in some way, and suddenly people become very aware of all sorts of other needs, multiple and complex, that can't be met through the ordinary business of relational breathing. Suddenly breathing in that way becomes very, very difficult. I think these people up here, real people, not just a Google image, these people have multiple and complex needs, but they're getting them met, aren't they? They're getting them met through falling in love with each other, having sex, having children, buying clothes, getting their teeth done, going to the park, having lots and lots of fun, to the point where, in the car on the way home, they don't notice that they have multiple and complex needs because they've just been addressing them, like breathing, like we've all been doing since we came into this room or since we were born. I don't think that's any different down here for this young man in terms of his multiple and complex needs, but let's assume that something about his early relational experiences has let him know that the most dangerous and crazy thing you could ever do is form a connection with another human being. It's just crazy, mad. And then met heroin at 14 and thought, this is brilliant. This is actually something I can trust and rely upon and depend upon, like I depend on my bikes or my records or my kids or all sorts of things. The needs, I think, fundamentally are at some level the same, but the way in which they might be able to become met is different. There's options that have become closed to people whose relational experiences have been so injurious. As I say, the madness would be that they came and trusted people. Of course, what's interesting, these are often people who we say are disordered, but of course the disorder would be if they came along and did trust people after some of the experience that they had. That would genuinely be a bit crazy, I think. I think relationships happen, trauma happens in relationships, and I guess ultimately that's likely where it's to be addressed. I think, how to describe it? I think we sort of underestimate the degree of the dosage almost, I want to sort of say, of what might be required to actually address some relational injuries. They are so severe that it cannot really be done on an outpatient basis for an hour, a fortnight or something. I'll just see you next week and we'll chat about stuff, and then we'll see you in 2 weeks' time. That doesn't really work like that. So think of again, going back to my children, I remember I was making some of the arguments for housing first about relational continuity, sort of trying to give the example of something like my son is 15. He's had 15 years of housing first. Like 15 years of it, like in a residential setting with myself, my partner, and he still can't find where his pants are. Like he's had 15 years of like relational continuity and support and availability, relative safe environment, and he's still not ready. Like he's still not cooked, he's still not ready. I mean, I wouldn't leave him for too long in the house by himself. But often we're working with people who didn't have that. In fact, they had quite the opposite. They did have 15 years, but it may not have been of that sort of relational stability, continuity. They have not been able to develop that sort of trust that Jude just takes for granted. I occasionally ask him, like, what would it be like, do you think, to live in a world where nobody had your back? You were completely on your own. There was no one you felt you could trust or rely upon. And he just looks at me like I'm mad. I mean, he has no concept of what I'm talking about at all. It's just, he's completely blind to it because it's not in his experience. And I think often we find ourselves working with people who can't understand what it might be when we say, look, I'm not your history. You could trust me. I'm going to care about you in a way that's not going to harm you or abuse you or damage you. Like, you're right. Like, I don't even know what you're talking about and what it might take to actually provide an experience that might start to heal that sort of relational injury. It's interesting when I compare these with other things. Like, it's interesting when you think about physical trauma. The consequences of physical trauma are much more visible, I think. So, for example, we have spinal injury rehabilitation services for people who have injured their spine through traumatic experiences like a car crash or whatever it might be. And that's right, and that's the way it should be. We can get into a cost discussion here as well, because often these are very high-cost services. Again, as they should be, there's nothing wrong with that at all. But if you try and find the relational injury rehabilitation service or the trust repair service, it's quite hard. I've not really found one yet. I've been looking for a good 20-odd years, actually, and I haven't managed to find one. A place that would really recognise there is such a thing as broken trust, smashed trust, severe relational injury, developmentally acquired relational trauma that might require long-term, relationally based repair. And that might take quite a long time. I haven't found that yet, really. It gets done in parts, and there's organisations that do it a bit, and we talk a lot about relationally based services, which is right. I find myself thinking, I wonder what the relational dosage of a equivalent of a tenner bag of heroin actually is. Like, what would you actually have to provide in terms of relational continuity to be the functional equivalent of what somebody happens to be getting out of their relationship with substances? In terms of adaptation and accommodation, again, I think there's an invisibility around it. It always interests me when you go to particular sort of services, like this is a GP surgery, and we make adaptations and accommodations for people with physical injury, as we should do. We have wheelchair ramps, car parking spaces, accessible toilets, wider corridors. That's the way it should be. And where's the adaptation and accommodation for relational injury? Where is it? It's often not there. In fact, if it's there at all, we assume, most health services, I guess to a degree, were designed by relatively healthy people, and we sort of designed them in our own image, which is an idea of, well, if I was sick, I would go along and I would ask for help, and I would be able to trust. I would be able to make a relational connection with the person who might be able to help me. And I think implicit within most services is that idea that people can do the relational activity required to access health. Like, there's a relational access bit there, which I think we don't really look at, but I think is really important. So, for example, we assume that people can do the relationship. Just come along to the trauma service. and meet the psychologist and go down into a room and have the door shut behind you and chat away to them about stuff. And we wonder why some of the people we work with, they'd be mad if they did that. That'd be crazy to rock up to a new building, sit in a waiting room, meet someone they'd never met before, go down some stairs, into a room, have the door shut behind them, and speak to someone they've never met before. That's going to be really tricky for a lot of people. We ask people to do things, I think, that we would never ask of people with physical injury. Like, we wouldn't go to a situation like this, a severe accident on a motorway, and go around to the people with their smashed hips and stuff. You guys really need to get to A&E. It's down the road. It's about 5 miles away. It's not far. Just get up and walk and get down there. And we certainly wouldn't then blame them for not turning out. Oh, well, they just didn't engage with A&E. We told them where it was, and they just didn't come along. Because we can see the injury. We thought, well, they can't walk because their legs are smashed. But in terms of relational injury, we can't see it. And we ask people to do things, I think, a lot, which they cannot do. Not out of badness, or out of being manipulative or difficult or not engaging, but because the injury is severe enough that it gets in the way of them being able to do the relational access that we are asking them to do. We've set up clinics and services all over the place, and I get it, that there's lots of multiple places we can go, but actually a lot of us can negotiate those fragmented services because we have enough relational capital to be able to go around and make relationships all over the place. It's not ideal, but we can do it, we can negotiate it. Compared to people where actually the severe injury is the relationship with care itself. That is the life-limiting condition. It's a massive, developmentally acquired, understandable fear of connection to any other human being, particularly human beings who say they're going to care about you. Because when has that ever worked out well? And there might be quite a lot to work against there. So occasionally I think we set up services, even ones where we call them trauma-informed. I'm not having a pop at anybody here, but we do this with trauma-informed, because we went and we didn't look to the trauma stuff. We had an afternoon doing it, and we do blah, 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 and nothing changes in terms of relational access, relational availability, where the person is, or a recognition that one of the most severe and long-standing consequences of early developmental trauma is relational injury that has a massive and life-limiting impact on somebody's capacity to access relational-based care. Because all care is fundamentally relational, isn't it? We don't say that, but the health service is, health and social care is all relational between a group of people called health providers and a group of people called patients or service users or whatever it might be. And the health is only going to happen if those two can get into contact with each other. And early adversity, trauma, relational trauma, severely has an impact on people's capacities to do that. But we still often locate the problem into the person who doesn't turn up, which again I think would be like putting a wheelchair clinic at the top of 3 flights of stairs and 2 escalators, and then blaming people for not turning up to it. Say, well, we sent you an appointment, we gave you a map and a letter with all the bus numbers on it and all the rest of it, and you just didn't come. Like, we were there waiting at 10 o'clock and you didn't rock up. And then sort of eventually discharge, you missed 3 appointments, so we're going to discharge you. But we have trauma services that will discharge people when they do not turn up to appointments 3 times in a row or something. Completely, we don't seem to recognise that we have put relational stairs and escalators between them and the front door of the clinic that they cannot climb. Not out of badness or laziness or anything, but because of the relational injury that they have suffered. There's lots more I could say, but I'll stop there. That's the final slide. I quite like this cartoon because it's quite funny, but it's also quite true that I think we're quite good at locating responsibility sometimes into the people with the least sort of power. And they might occasionally be saying, yeah, but you put your clinic on the top of 3 flights of stairs and 2 escalators. Go, yes, but you didn't turn up. Like, we're often quite good at projecting the sort of fault and the blame and the weakness into the people who have the least power to do anything about it, really. So that would really be all I'd want to say. Is I think the bit about the mental health services was to say, I would be arguing for a much broader sort of mental health service that encompasses all the things and more that I put on the slides there. But fundamentally, I think we need to think, when I'm talking about trauma-informed service, I think we really need to shine a light on this sort of invisible process that sits underneath all that we do, which is the relationship between ourselves, and how, when we're actually talking about trauma, for me, I think at least one element of it is that we are talking about relational injury, severe relational injury. Now that's a term I sort of vaguely made up. As I say, we don't have relational injury services in the way that we have services for other sorts of injury. But I think it's something we might need to pay attention to if we wanted to make better connection between ourselves and some of the most injured people in our society.